about how I could, make it work and be present for my patients and also present for family. So it was something that was very stressful, leading up to it. And I think one of my close friends gave me really insightful way to think about things, about how your life changes after you become a father. And what he said to me was, you can't really explain it, but once you become a father, you just have this clarity on, what your purpose is and, what your mission in life is. And I thought that was really, really well said. And it's true. It's just like, it's a different lens that I'm viewing my life in now. And I just get really excited, going home, or even though I'm tired getting up early, when he's just like looking in the crib smiling at me, it's like, I'm really tired, but okay, we'll go, play on the mat for a little bit.
Welcome to the Critical Chats podcast,
or as I'd like to call it, Crit Chat,
where we talk about the new and exciting developments in the critical care world and get to know the providers behind the medicine.
I am Sheila Billica, PA.
And I'm Katie Shakura, PA. We're your hosts, and we're with our producer, Sneha.
I'm also a PA.
3 PAs on a pod.
We are here with Dr. Toomey, who graduated from the University of Rochester, New York in 2016 and went on to have not 1, not 2, but 4 board certifications in pulmonary and critical care medicine, hospital and palliative medicine, and internal medicine.
He's one of the most kind and level-headed physicians we have here at UMass, and we are honored to have him as our guest on our podcast today. This is going to be a juicy episode. He's got a broad range of interests, ranging from health equity and LGBTQ health and to quality improvement and communication in healthcare. He loves outdoor activities and just recently became a father to the cutest little boy, Parker. Dr. Toomey, thank you for joining us today.
Yeah, you guys are flattering. Thanks so much for having me. It's such a privilege to join the podcast, and, thank you for doing all of this hard work and, making a venue for us to talk about who we are and what we do.
And something very important. And also 4 board certifications. You look like you're 20 years old.
Yeah, yes. They just keep adding up, I guess.
Yeah, tell us more about that. Tell us about your education background, your interest in critical care, and what you like to do outside of the hospital, obviously, and what life is like as a new father.
Okay. Small questions. So I guess, how do I start? So I kind of knew that I wanted to go into medicine in my high school years. I was a wrestler and did some other sports and had really good interactions with an orthopedic surgeon when I got injured, and was always kind of driven to science and thought, how much he helped me and how that would be a cool field to get into. So that was kind of the view that I got interested in medicine, and eventually went to University of Rochester for medical school, where I thought I was, going to go into orthopedics because that's what driven me into the, medical field. But I tried to keep an open mind and have good experiences, and I was really drawn to the ICU from my early clinical years. I had some early ICU exposure, and I loved the acuity, the intensity, the kind of the protocolization to an extent, and the sickest patients in the hospital go to the ICU, and I was just really drawn to that. And I didn't know if I wanted to, what venue I wanted to go into the ICU. So I was trying to decide whether, a surgical career or, an anesthesia career or a medicine career or, even, emergency medicine. And I eventually decided to go the medicine route solely because I really enjoyed the way medicine thinks about people and how they approach problems. And I thought that was a really nice skill set to the, complexities of patients in the medical ICU. And so when I was training in Rochester, there's a very big, palliative program there. And they're kind of one of the leaders in the country as far as that. So we have a lot of exposure during medical school. And I knew that, part of the ICU that drew me in was, the really good outcomes and the aggressive care, but also the importance of, of end of life care, and how in the right skill that could, that's a sacred experience for patients and their families, and, how we can do a really good job in those patients as well. Even if we define that as, a bad outcome in the ICU, we can still make it a good outcome for patients and families. So that's what kind of got me into thinking about palliative care. I went to UMass. I did my medicine residency there, and then pulmonary critical care. And then I was, deciding on whether or not I wanted to pursue more training, because after, residency and fellowship, I was, getting tired. But I have a lot of good mentors at UMass that helped me think through it, and I thought it was a really important experience and training for me to kind of give my own overall career goals and stuff like that. And so they advocated for me to do it, and I ended up staying at UMass for the palliative care fellowship as well. And now I'm, faculty there.
That's awesome.
They couldn't get enough of you.
Or I can't get enough of them, either one.
You were the right person for this.
Yeah.
Oh, thank you. Thank you.
And I like how you talk about how, it's a sacred experience for the patient and for their families, because I feel like for us, it's like critical care. It's just our day-to-day job. We go in, 6 a.m. or whatever time you guys as attendings come in, leave at 6 p.m. and, do it all over again for a couple shifts in a row. Whereas like these families, like this is some of their worst days of all time. The patients, if they're, with it at all, absolute misery. So it's truly like a moment. It's very, very special that we have the opportunity to be with these patients in their sickest moments. Like it's really, really special and beautiful.
And outside of our medical care, our interpersonal interactions with patients and their families are things that can really help situations or really hurt situations. And regardless of the interaction, these are things that patients and families will remember for the rest of their life. And, we do too, but.
Absolutely.
Yeah. I was just going to say, like, just to bring it back a little bit, because you are a new dad as of 6 months ago.
Yep. Hot off the press, 6 months.
Still new with the tags on.
Mm-hmm.
So Parker.
Babies come with tags on?
The babies do come with tags. You have to rip them off.
I didn't even know that.
Yeah, there's like these like ankle bracelets with a monitor that if you take them out of the hospital too early, then the monitor beeps.
Okay, I see.
Yeah. My son, the tags are still on just in case I have to return him, because I'm trying to expose him to different foods. If he doesn't like the foods, I'm going to return him. So I don't know if you have the same experience, but it's pretty brutal. So yeah, how has that been, especially like with your career? Your career is very tough, very intense. And then you come home to this like beautiful little boy that's like, brings out the levity and all of that.
Mm-hmm.
So you live the beginning and the end every day.
Yeah, that's a good way to put it. I'll say fatherhood was something that I was very nervous about, because, being a junior faculty, just starting my career, having all of the inefficiencies associated with that, long hours in the hospital, worrying about how I could, make it work and be present for my patients and also present for family. So it was something that was very stressful, leading up to it. And I think one of my close friends gave me really insightful way to think about things, about how your life changes after you become a father. And what he said to me was, you can't really explain it, but once you become a father, you just have this clarity on, what your purpose is and, what your mission in life is. And I thought that was really, really well said. And it's true. It's just like, it's a different lens that I'm viewing my life in now. And I just get really excited, going home, or even though I'm tired getting up early, when you just like looking in the crib smiling at me, it's like, I'm really tired, but okay, we'll go, play on the mat for a little bit. So it's been a big change in kind of structure of day, and, trying to become more efficient and spending time with him and maybe doing some work after he goes to bed or something like that. But it's been awesome. It's been a lot of fun.
That's awesome. Yeah, I feel like you have to like really soak in those tender moments, and yeah, I completely agree with everything you said. So back to your career, how would you say you define hospice care and palliative care? Because I feel like there's a lot of people that are confused by it, especially patients and family members, when you say like, what if we were to consult palliative care, and they're like, oh, we're not ready to pull the plug, and then it's like a whole bag of worms there.
Yeah, I think that that's such a important topic to talk about, because understanding the difference between palliative care and hospice and how we introduce palliative care, either from the primary team saying we want to consult them, or when I see somebody for the first time, how I explain things, really starts the visit off, and has us take a good jump forward. And you're right that palliative care is oftentimes used synonymously with end-of-life care, with hospice care, and it's it is different. And when you go through medical training, and there's the adage, you don't know what you don't know, and that was really me when I went into palliative fellowship. Was I thought I had an idea, but there was so much I didn't even know that I didn't know. And so one of those things is how to introduce palliative care and how to talk about what we do and what vocabulary we use.
What do you use? What vocabulary
Yeah.
do you use?
So what I would say is palliative care is a specialty in medicine that functions as an added layer of support. And we learn about who patients are as a person and what they're experiencing through serious illness, and focus on strategies to help improve quality of life and relief of suffering, and also having patients understand their medical condition and different kind of options for care, and making sure that they get the care that they want and not the care that they don't want. And palliative care is kind of the overarching field that hospice care is a part of, but hospice care is really specifically palliative care at end of life. And palliative care can see patients in all spectrums of disease, even patients undergoing curative treatment. And so, I think it's a much more upstream intervention than hospice, and that's really where the money is having early palliative care, learning about patients and their families and what they're experiencing, and then working on treatment decisions and more end of life care when you already have the relationship, and it's not like coming in and talking about the unthinkable with a new face. And I think it's an important distinction between palliative care and hospice that it's a mouthful. And I probably could have synthesized it a little bit more, but we have a lot of different ways of different providers that talk about palliative care. And kind of the analogy that I use, because I like to give an analogy after I give my spiel, is if you're a patient, think that you're in the driver's seat, because we want to keep you in control, and the driver of the car, the pilot of the ship. And you can think of palliative care as like I'm in the passenger seat with the road map, figuring out where to go, and also adjusting the temperature and making sure it's not too hot, not too cold, making sure you're staying awake and those kind of things. So it's like the co-pilot to your journey through serious illness.
But not necessarily being like a backseat driver,
Yes.
which can be very problematic.
How about chronic pain management at the end of life? Are there any new developments, anything new that you want to share with us?
Yeah, I think so. A big kind of push in the palliative care world is we're starting to use buprenorphine more, which, as we know, is it's a high affinity partial opiate agonist, and there's a lot of good. So it was classically designed in substance use disorder and to maintain sobriety, and we're finding that For more longer-term opiate therapy, it's a much better alternative than the classic opiates. There's less side effects, and in palliative care, there's been a push to kind of use it more, and the use is a little nuanced and can be uncomfortable for a lot of different, specialties, particularly when they, are admitted to the ICU. And so I think the overall tenets of pain management and symptom relief at the end of life is pretty constant. Opiates are first line, and we, have good understanding on how to use those and things like that. But I think the more nuances that we're going to see, down the line is these patients that are on buprenorphine that come into our ICU, and how do we manage the buprenorphine? What are differences about it?
We're scared of that drug, by the way.
Mm-hmm.
Yeah.
Terrified.
Yeah. And it's really because it's not something that we have familiarity with, right? And so we don't know how to manage these things. And so, yeah, there's, particularly in the perioperative world on, what to do with a patient who's using buprenorphine when they're having a procedure. And, classically we would have the patient stop the buprenorphine so they can get general anesthesia and then work a way to transition them back to buprenorphine. But there's more evidence now that keeping the buprenorphine on and then kind of treating the acute pain on top of it is kind of the recommended strategy now.
That's okay.
Mm-hmm.
That's good.
Yeah, so that's that's kind of the next frontier, and you can see, or you can imagine in our ICUs in patients who become critically ill, who need mechanical ventilation and sedation, what to do with the buprenorphine. Should we keep it? Should we add sedation on top of it? And those kind of things. And I like to keep it on in my patients solely because it's much easier to keep it through than to work about cross tapering or precipitating opiate withdrawal to restart it when they're recovering. And oftentimes you can get really good effects with a high affinity opiate, something like a fentanyl or a hydromorphone, and you can get creative with other sedatives as well, with the benzos and the propofol and the ketamine and those kind of things. And so I find that I can still for the most part give adequate sedation even with the buprenorphine on.
That's good.
That's very cool. Do you use like ketamine at all in terms of like kind of palliative management?
I'll say that I'm still pretty early on in my career. I use it mostly in the ICU because that's where we kind of use it at UMass, and there's not a lot of protocols on the floor for it. But there is good evidence, and there's been some pushes to use ketamine, particularly in sickle cell patients that are coming in with pain crises. And so there's more on the horizon about potentially maybe using ketamine outside of the ICU for specific patient populations to have better pain control. But we're a little ways away from that. You have to have the protocols and make sure that you go through all of the right avenues to make sure it's safe, and have everyone trained and the nurses trained and things like that.
Are you do you need help writing these protocols?
Shayla's looking for like yet another thing to work on. Not to go back to our last episode, but
I like rules. I like rules and protocols. Like you were saying, for in the ICU, we have those protocols and they are helpful. So I like that. So that's what I'm volunteering. Because I feel bad for patients who are in pain and who have been on their own management, and we come and disrupt it, and we don't know what to do, and they are at a loss, and then they go home, and then they have to restart everything all over again. So
Yeah.
you know how that is.
Yes.
yeah, I guess like for us working in the ICU, we don't always consult palliative care when it comes to our patients' end of life, whatever. Oftentimes we end up having those conversations on our own unless, we, for whatever reason, opt to. Are there anything specific in palliative care that you feel like we should know, or we should like anything new that would be helpful in our management of our end of life patients in the ICU?
From a symptom perspective, from like symptom
I
control,
think
or
symptom, I think, emotionally, like any of it.
okay,
Any advice you would give to us?
let's start with symptoms first, and then
Okay,
we'll talk
great.
about communication. So for symptoms, I think one of the biggest difficulties is how to manage a symptom crisis when we're, say, withdrawing life support, or having weaning something that's going to precipitate symptoms. And oftentimes in the ICU, there's a push for starting infusions and having opiate infusions or benzodiazepine infusions to relieve symptoms. And what I'll say is, in practice, infusions are needed for some patients and very helpful for some patients, but really, in that crisis point, starting with bolus dosing of opiates, benzodiazepines for whatever symptom they might have, and getting an understanding of the dose, because sometimes the symptoms are transient, meaning that we're weaning the oxygen and they're going to get dyspneic and need pre-medication for it. And just because they need pre-medication doesn't necessarily mean that they'll need continuous opiates. And that I feel like that concept is hard to break a hold of in the ICU, because we have many patients on sedative infusions, and how we manage those things. But the infusion, when you just keep increasing the infusion, it's going to take a long time for us to see that effect, whereas the boluses help the symptoms right away. And if the boluses are frequent and needing them a lot, then you start the infusion. And I think that concept is something that's really hard to change culture and change how we think about things. But that's kind of the next phase and the next point of emphasis for me that I'm going to try to be working with.
I like that idea. But I find that it was supposed to be like that. I feel like in the beginning, that's what we did. If our boluses were too frequent, then we would start a drip. But now we start with the drip,
Yeah,
and I agree with you.
People almost feel like they can predict what's going to happen, and it's like, why don't we just start with the minimum
Yes.
and go from there?
Yeah. Sometimes less is more, and giving, if we can give less and then increase in a steady manner, I would think it's better. Is what you're saying.
yeah. And so the goal is to use the appropriate amount of medication to relieve their symptom and to relieve suffering. And the
It is
worry,
not euthanasia.
right, the worry is that if we are making changes to continuous infusions without using boluses, then we, may not be treating their symptoms acutely well, and we could have oversedation. And that concept of using medications targeted at symptom relief, which might have the side effect of some sedation, is our goal of end of life care and comfort care in the ICU. Whereas if we are using medicines to reduce consciousness, to not be aware of the suffering, then that is a whole nother kind of moral and ethical concept, and that's more palliative sedation, which is a much higher level concept ethically and morally. And there needs to be really specific protocols in place. But when care providers often think about comfort measures, that's what they're kind of assuming is the palliative sedation. And I think that's at times can cause families hesitation to focus on symptom management and comfort, because the worry is that they're just going to be over medicated, and we could even hasten their life, which is not the goal of our care. And using the boluses and kind of going back to the roots of the pharmacokinetics and pharmacodynamics on the bolus and infusion strategies, like any other medicine that we would use in the hospital, is a better strategy moving forward. Heparin drip, sedation protocols, insulin drip, Lasix drip, they're all kind of the same principles.
Now, in terms of communication,
Yes.
how would you, if you were to give us advice, honest advice about how we manage patients in terms of goals of care conversations and sort of approach to just like presenting, end of life, these like very like acute patients, what advice would you give us?
I think so. Whenever we are talking about goals of care and sharing some kind of prognostication with patients and their families, and then aligning care based upon that prognostication with their goals and their values and their wishes, is kind of the big topic that we're thinking about. You can't really do that unless you understand about the patient. And so it's really important. I find that before I go into information sharing and prognosis sharing and those kind of things, taking a step back, spending some time to understand about who the patient is, who they are as a person, what their life's been like, what's their family like, what have they shared before to their families, if and when they were to get sick, have they shared about that? And then using that as a lens to talking about what they understand and, sharing our prognosis and things like that. One thing that I will say that is very important and often overlooked when we're starting to share information is asking the patient if they're, first of all, okay talking about the information, and then asking about what is their preference for how they want to receive the information. Meaning, is it okay to talk about what we're seeing now and what the effects this might have? Or, is it okay to talk about timing? Is it okay to talk about changes to your function? Because when we think about prognostication, we often think about, in the ICU, it's pretty binary, like, are they going to survive? Are they not going to survive? But prognosis is so much more than that. And it's the other parts of it that I think help patients and families think through decisions more.
I mean, like their day-to-day and their ADLs and stuff?
Yeah. What is the effect on their functional status? If they do survive, what can we anticipate life looking like?
And did they have a big plan to go to a wedding or a special wedding, and what do they want? Do they want to arrive to that
Be with their
part
grandchildren, or see.
stuff like that?
Mm-hmm. And then using those goals to understand what's feasible and what would be feasible with certain interventions, what wouldn't be feasible with other interventions. So I find asking permission and using prognosis as more than just timing. It could even be things like, we're worried that they might not ever come off of the ventilator, or we're worried that they might not be able to leave the hospital. And then that opens up bigger questions over what does living mean to the person? What is their kind of important aspects of quality of life? What is so meaningful to them that they couldn't imagine living without it? All of these questions, the trade-offs, the functional abilities, those kind of things that help us kind of have a formulation of who this patient is, and kind of allows us to kind of think through things in their footsteps. So I think that's how I would describe prognostication. And then when you're having a family meeting, one of the big interventions that we do is we talk about information, and then we talk about all these care options, right? And the kind of the really good part about family meetings is at the end, when you talk about different options, and then you can say something about what we understand about you or your loved one and what their preferences were. In hearing about the options, I would actually recommend this option because this makes sense medically and what they who they are as a person and what their preferences are. And so I really think making recommendations is important. We do it in so many other aspects of care, with medications, with lab tests, with all of these things. And it's okay to make recommendations to patients and their families about this too. We're kind of functioning as the translator for what we're seeing and what we can anticipate, and why wouldn't we help them make this decision. we don't have to force a decision, but a recommendation is a recommendation, and that can be appreciated or not appreciated.
How do you go about, or how do you deal with family members who don't honor the wishes of
The backseat driver.
yeah the patients? That bothers me a lot, and I always think, okay, is it because they don't they they can't, they are not ready to say goodbye for real, or because they don't know how to say goodbye? But why, how we're so much better at taking care of our pets, giving them comfort, that than we are at doing that for family members, I find. What do you think?
Yeah, it's such a complicated issue, and I say that because there's a lot of different layers to this, and I think that being in the ICU and caring for patients and seeing all of the aggressive interventions that we do that we may not think would change the overall outcome, that makes us feel bad, because it makes us think that we are promoting suffering and we're not helping. And what I would say is suffering means different things to different people. And our impression of suffering is our own impression. And it's natural to feel that someone else is suffering, because if we put ourselves in their shoes, then, we would be suffering doing that. But it's helpful to individualize things and not necessarily focus on what we would want, and more taking a big step back and understanding what suffering means to that patient, and how do we define that, right? And what does quality of life mean to that patient, because everyone has different preferences for everything. And so coming at it in a curious and empathetic way, I find is the best strategy. And oftentimes the moral distress that comes with caregivers providing care that we may feel is not helpful or not beneficial, that's a natural thing, and we see that a lot in the ICU, and that correlates to a lot of burnout as well. And being able to, when there is conflict, meaning that in the situation that you expressed, where maybe we know a patient's wishes that they have stated before, and the family is choosing different pathways, you have to understand why. Why are they choosing this? And it's okay to ask this in a compassionate and empathetic way, saying, I am seeing that your loved one has displayed preferences before for these things, and we are choosing a different pathway. Can you explain to me a little bit about that decision?
One family member said to me, that's because they didn't know that's how their life was going to end up. I was like, okay.
Yeah, I feel like it's so tough when you're, young and healthy to think about yourself in a scenario like that, which I think is why it's important to have these conversations with family members when they're healthy. I'm trying to get both my parents to do healthcare proxies.
Yeah.
Have updated wills, because, and not because I'm obviously I'm always worried, I'm always anxious, but I just want to have these conversations when they're healthy and know what they're about, because even if it's not what I want, I think it's such a blessing to it's honestly a gift to receive that from family, just that knowledge, because then when the time comes, it's not your burden anymore, because you're just going to merely be following your family member's wishes. You're their advocate, you're their best advocate. So it's let's have these conversations at the table. I feel I'm I talk to these families, and things happen and I'm like, okay, now like you guys should all talk to each other about this. Like if it hasn't been discussed before, here's your avenue.
Yeah, and it's important, to have the conversations. It's so much better to have these conversations about preferences when we're feeling well and we're not feeling bad, and it's not an emergency, and there's some time sensitivity to it. And so, yeah, that's great. And the other thing is, I feel like the more beneficial conversations, like if I'm talking to my loved ones, is not as much black and white things as far as like, would you want to have your code status as full code, or would you, want to be a do not resuscitate? It's more kind of bigger concepts over what is really important to you, what would not be acceptable to stay living, and those kind of things.
And they're morbid conversations, but I think,
Yes, they are about death. They are morbid.
that's true. That's so true. But yeah, they're dark. They're dark conversations, but I think they're necessary to have. And it's like, people don't like to talk about death. It's scary. But it's also like, it is beautiful to be with someone in their last moments and like, how they envision death. Do they envision I mean, no one really envisions their own death, but like at home with your loved ones surrounding you, I'm like, that is the most beautiful way. But like, everybody has their own thing. I mean, that might not be what people envision for themselves, but I don't know. It's just such like it's as beautiful as birth. Like, how profound.
Yeah, it's, happens to everyone. And, one of the phrases that I like to talk about with my patients and families is, we may not have control over that you're dying, but we do have control over the journey. And how would you want that journey to look like?
That's beautiful. Well said.
Because there's a lot of great medicine that we can do, but it only works so much. And at some point we may have to decide over what we would want that journey to look like.
Yep. Do you have any advice for us providers who struggle emotionally with terminally ill patients?
Yeah, my advice is that it's normal, and that so much in medicine is we don't talk about these things. But part of what drew me to palliative care, and kind of one of my tenets in medicine, is the humanity of it, right? There's an art and there's a science, and it's human to feel sadness for your patients. And, ignoring that or not talking about it is a way to keep those issues kind of boiling inside you. And so I would say being honest about it, and it's normal to feel that way. And in palliative care, we do a lot of kind of rituals with our patients, or with our team, about our patients, over remembering them and thinking about them. So every week we kind of read the names of patients that have died under our care, and we have a moment of silence. And one thing that I started doing in the ICU, which I think is really helpful, is after a patient dies in the ICU, we read something called the pause, which there's a bunch of different pauses out there. I think the one that we use is from Cleveland Clinic, or kind of I have that, and then I kind of edited for my own phrase, just to honor the patient that died, honor the family, and honor our care that we gave them.
I think that's awesome. We should use that. And I do like the idea of like reading people's names, because, it's really, I find it so hard. Like if you're taking care of people for, if you're working like a bunch of shifts in a row and you're just really going at it, doing everything you can for that patient, and then they pass, like it is just so emotionally draining. Like those are the days that I feel like make me burn out faster than like some of the harder patients. It's just these like really intense emotional experiences. But yeah, I think that would be really helpful.
I agree. We should talk more. Families should talk more. Everyone listening should talk more about
And like, don't be
death
afraid to
with their
break down that
family.
fourth wall and like, like, you know, obviously you don't want to be in hysterics with the families, but like being emotional, showing them emotion, showing them that you care about their family member, like that can only be good.
Yeah, that's something that I've struggled with throughout my training. Is I am a very emotional person, and I have a hard time not showing emotion at times. And I used to really worry about the optics of that when I'm talking with patients or their families. But I'm human, and I do care, and why wouldn't I show emotion within reason?
Yeah, and that's why you're so good at your job. I mean, how can you go into that field? How can you have 4 board certifications? Guys, 4 board certifications.
4.
How can you go into that without any sort of humanity? Like, clearly you're drawn to medicine and drawn to your patients, and like you want what's best for them. Like, I don't know. I just think it would be crazy to just pretend that you don't feel anything at all.
Yeah, and that's what when we don't talk about these things is when we get more burnouts and have career changes and those kind of things. And part of the ICU, is what can be really difficult is a very charging emotional case that the patient may have died, and once the room is clean, another patient comes in the room, and you don't even have time to take a breath.
I know.
That's right.
And they're like, we got one for you. Like, there's a patient who's in the ER that's been waiting for a bed for 3 days.
And so being deliberate over whether you want to debrief the case right then and honor them with the pause, or saying, there's still a lot of processing that's going to need to happen here. And we as a team should talk about this. Now's not the right time because there's another patient coming in, but we need to schedule something to all talk about it. Because the processing is something that we all need.
Yep. Yep. Well, I could talk to you all night long, all day long, all week long. However, we need to do the thing.
Yeah, so hit it.
All right. So, what is your anthem song?
My anthem song?
Mm-hmm.
I guess so. When I went through pulmonary fellowship, the first year of fellowship was the first year of COVID. So it was a very
Very apropos, but very hard.
yes. And a lot of hours. We were spending a lot of time with each other, and I forget how it came about, but the song "Taking Care of Business" came on, and it was like such a coping way for us, where we were working way too long and way too tired, but having the "Taking Care of Business" was kind of helpful to keep one foot in front of the other, and keep moving on. So I would say "Taking Care of Business."
I feel like I'm going to listen to that on my way home. Yeah.
Sure.
Well, thank you so much for coming on this podcast. Like, this is such a great topic, and I feel like so many people can benefit from just like hearing your wisdom. So we really appreciate you taking your time.
Yeah, I'm not sure how much wisdom I have, but I'm happy to share my experiences. And this is a field that I'm passionate about, and needs more conversations. And so this was a lot of fun. Thank you for the opportunity.
Absolutely.
Is there top 3 things that you do when you had a tough day? Sorry, I just have to ask you that question.
A tough day? Let's see.
Top 3 things.
Yeah, maybe like some more advice.
Well, now it's spending time with Parker for sure.
For sure.
My kind of way that I have been distressing after work has been, I really like taking my dog for a walk. And
What kind of dog do you have?
I have so he's a rescue, and he is a big mix. He's a German Shepherd, Belgian Malinois, Chow.
Oh, wow.
There's like a Rottweiler and something else.
Medium size?
Sounds large.
It's all large breeds, but he's like 60 pounds. And yeah, I love just taking him on a walk, listening to some music, and kind of just being present with him.
That's 2.
Okay. The third one would be, so I have a very close relationship with my family. And so usually when I'm driving home at night or when I'm walking home, depending on where I'm going, I'll always call either my parents or my brother, or and have that time to just kind of talk about their day and, learn about that. I would say talk to my wife too, but I talk to her at home. So she's 4, because I can't not mention her as well, because she's a
Just
an
because,
important part.
she's going to listen to the podcast, like we have to mention
Well,
her.
no, it's because she's important,
Oh,
Katie.
got it.
All right.
And this playhouse that you've created, can you tell us about this? Because I don't think our listeners know anything about this, but this is a huge feat that you do on the side of everything else.
Oh my goodness.
Playhouse?
Yeah, so my brother had the first grandchild of my family last April, and Parker was born in February. And so they're about 8 months apart or 10 months apart. And my parents love being grandparents, and it's been such a fun change seeing how they've changed with the new grandchildren. And part of that is they want to have like a really fun, environment at their house. And so we had this idea of making like a fort for them, where Parker and my nephew can go and play and like hang out. And it just really took off and got way more aggressive than we had thought. And so we ended up getting like a house kit that's a full-on kind of house with pine that has a roof, and there's now a fence.
It's like a shed, essentially. Like you built a shed.
Mm-hmm. With windows and a door, and we put a mailbox on there. And so it's their little like fort. And then, we've been doing a lot of stuff at their house to make it fun for them. So that's been a outlet for us too. My family is very kind of into projects and doing things, and that's how I think we kind of, go about our day and, how we occupy our time. We're always looking for different projects.
That's awesome.
I'm jealous, not even for my son. I'm jealous for myself because I want a fort.
I know when we were seeing it, we were like, oh man, this is pretty sweet. We could hang out in here.
That's awesome. Thank you again, Dr. Toomey.
Yeah, of course.
Dr. Toomey, we appreciate your time.
We really appreciate your
No,
time.
thank you for having me.
Thank you for joining us on another episode of the Crit Chat podcast.
It's critical chat, Shayla.
Remember, you can watch the podcast video on YouTube or listen to us on Spotify, Apple Music, CastBox, or Amazon Music.
Everywhere.